Uh, Hello everyone. Welcome to another Wednesday VMR. Sharmin here. I'm so excited to be here with the one and only Masa, uh, who I have the privilege of co-discussing with. Big shout out to Himon for presenting a case, Magnus for doing teaching point, and Julia for scribing. Masa, do you want to say hi?
Hey everyone, happy Wednesday. I'm so excited for my discussion with Charmaine. And thank you so much, Hemon, for bringing this case. And thank you, Magnus and Julia, for supporting the session. Super excited.
Yo, Masa. We're super excited. Good to see you, Yusuf. Good to see you, Jazz, too. All right. Just gonna help myself. All right, if you can get the board up, we can get started.
Okay, so my honor to present this case to our amazing teacher, Charmaine, and the wonderful friend, Masa. Okay, let's start. Chief complaint is nausea and vomiting and tachypnea for 2 hours. HPI, 37-year-old male was found unconscious after co-ingesting alcohol with an unknown substance following an argument with his girlfriend. He presented with vomiting, diarrhea, sweating, dyspnea, muscle weakness, and urinary incontinence, and was disoriented with a strong garlic odor. Meiosis, bradycardia, bronchocardia, and fasciculation has been observed. I will end it here for first allocate.
Oh, right. Wow, this is a very exciting start to the case. Masa, what's jumping out to you?
Okay, so he was found unconscious. So first thing, I just want to make sure he is stable. So I just want to take a look at his airway, make sure it's patent, his oxygen saturation is good, his blood pressure is stable, his heart rate, and then I want to just get I want to get his blood glucose and just rule out like altered mental status mimics, kind of like, yeah. And then I also want to do MIST. So if any metabolic causes, so just get like his urine and electrolytes, a basic metabolic panel, and look for any infections, get a CT scan. And then after we stabilize him, for nausea and vomiting, that's quite non-specific, but since he had alcohol recently, I'm wondering if this is just alcohol poisoning or if there's something going on with it, because he had, let's see, sweating, dyspnea, muscle weakness, urinary incontinence. Is cholinergic substance, I'm not sure if this is like the opposite of what cholinergic substance intoxication would present as. I think that one was like urinary retention. But yeah, I would just like look out first for his electrolytes and yeah, stabilize him. I'm not sure what to do with the garlic odor. He has bradycardia, bronchoria. I'm not sure what bronchoria is. Yeah, that's basically it. I don't know, Charmaine, what do you think?
I love that discussion, Masa. I think that the way you're thinking through it is exactly what we're supposed to be doing. So I love the fact that you started from the get-go. It's like if I'm seeing this patient, you're telling me he's unconscious, and my first priority is to make sure that airway is secure, that they're stabilized, and then like treatment before diagnosis, just to make sure that the patient is safe. So going to your ABCs, getting a GCS score, making sure the patient is like protecting their airway, and like their vital signs are stable, and then that give us like a little bit of time to think about. And I really love that I think like the garlic odor, meiosis tends to be a little bit of a buzzword, but like standing back and saying like, or else what else could this be? And like being thorough and thoughtful, because if he ingested some substance, I don't know what else he could have done, or did he have a fall, hit his head? So really like still being true to our, this patient is coming with a kind of a loss of consciousness and he's altered on exam, and staying true to our lovely acute altered mental status buckets of like metabolic issues, infections, structural, and toxins. And for this person, I think there are more signals for the toxin aspect of it, although the structural part, I'm never opposed of getting a non-contact CT, especially if this patient was like unconscious, if he, especially when he became unconscious, if there was no witnesses, just to make sure we're not dealing, in addition to whatever the toxin is, it is whatever the toxin, whatever the toxin is, to make sure we're not dealing with like a brain bleed as well. I think like the consolation, so like alcohol oftentimes, intoxication, as people start, then people are altered, there can be like a bit more somnolent, and as they start withdrawing, they can become more tachycardic, they have more hemodynamic instabilities, which doesn't go with really like the meiosis, the bradycardia. The garlic odor often makes me think this constellation of like nausea, vomiting, like muscle fasciculation. It is a little, to me, brings up organophosphate toxicities. Like, if he had with alcohol ingested any like like a pesticide or a type of phenomena, that like oftentimes what happens is like organophosphate inhibits like acetylcholinesterase, and it causes both like kind of like, if you remember the muscarinic and nicotinic receptors, and you get overstimulation of the nervous system, and oftentimes people have like diarrhea, like they lose control of urination, they have like bradycardia, they're vomiting, and a lot of like salivation, which I don't remember if this patient had. So it oftentimes like you see a lot of like parasympathetic tone up front. And then the muscle fasciculation tend to be more like a nicotinic aspect. And then the CNS effect of it is a lot of like, if I remember correctly, I think it can cause seizures too. So this is someone good to, to have like to monitor very closely for any seizures. So I think the things that we just want to make sure at this point is to make sure, his airway is protected. And I oftentimes like, I think antimuscarinic is what you want to give, but what I would personally do is that like make sure, as you mentioned, we get this patient stabilized. I do like a thorough workup to begin with, and in general here we call poison control to help us with the next step. So we're like this patient, and I really love talking to them. They're incredibly educational. I learn a ton every time I talk to them about any substances. And this is the case that if I were in the emergency room seeing this patient, I would call them here and like run through them, and they will tell you like exactly like what they're worried about, what else like the substances tend to be laced with that you should have to worry about, what to do. So yeah, that's where I would start. Any other thought, Masa?
No, I think the organophosphate poisoning is what I was thinking about. And then also, as you mentioned, like we don't know what else he took. So maybe he took like morphine, because like the meiosis and the tachypnea as well. So a Utox could also help us a lot here. Yeah, that's it.
I love that. Yes, Utox would be really helpful. Alcohol level, yeah, totally. All right, Hima.
Yes, amazing discussion, brilliant. Yeah, so Masa, we did a glucose. He didn't have any hypoglycemia, and also CT head was normal, and there was a brilliant Mahalat. Yeah, we asked for his job, and he was farmer. And yeah, so let's look at in hospital. we were also thinking about organophosphate, so he was decontaminated, and we discussed with a poison control and given oxygen, atropine, and polydioxin. But due to his tachypnea, respiratory rate was 40 per minute, and hypoxemia, PaO2 was less than 50, and mixed acidosis, like pH 7.288, and PCO2 was 41.9, HCO3 was 20, and he was intubated and mechanically ventilated. 1 day later, he developed fever and dysphagia, dysarthria, and head drop, and proximal limb weakness, causing difficulty lifting arm or like walking. Yes, I will end it here.
Oh my God. We're going on a roller coaster of a journey, Hiba. This is such a fascinating case. All right. Martha, sounds like the person had to get intubated, which is oftentimes, sometimes the safest thing you can do is protect that airway. And then now is having some new symptoms of fever and some neurological syndrome. What are your thoughts on it?
This is the tough one. So, okay, so he had a fever later. I mean, if it wasn't for the fever, I would say like maybe he developed a clot while he's in the hospital. But with the fever, I'm not really sure how to tie that in. He's been having dysphagia, dysarthria, and a head drop. I mean, I don't know why I'm like kind of thinking of botulism because of like the head drop is like kind of floppiness, I guess, especially the difficulty arms and lifting his arms or walking. Proximal limb weakness. I wonder if he just triggered an episode of myasthenia gravis because of the bulbar symptoms and the proximal limb weakness. Yeah, that's kind of where I'm at. I want to bring neuro into this.
Yeah, this is scary, right? So we've given the atropine and we've given uh oh, sorry, I forgot to mention this, like a bronchorrhea, which is hard for me to say. It's just like a lot of secretion from your lungs. Fancy way of saying it. So this patient came in, got atropine and got a pralidoxamine for treatment, which sounds like it the atropine is like antimuscarinic. It helps kind of like decrease the bronchial secretions, and the pralidoxime is for kind of like to reactivate those synapses, if I remember correctly. A couple of questions that I don't know, and I'd be like personally looking this up, is that if this was given once, like how long does it last, and is it possible that we are still like we damp down the organophosphate and the medications are wearing off, or he had like such degree or severity of like ingestion that we're still seeing the organophosphates at work. The other things that you want to also think about, or we should also think about, is that is there a complication of a potential medications that she's got, or a complication of the underlying disease? The one thing that he's definitely at risk of with the fever, I often think like, okay, he's inflamed, and especially with all the secretions, with all of things, he's definitely at risk of like developing an infection, like an aspiration pneumonias would be on top of my list. The other thing that I would that I don't know off the top of my head, but like in terms of like GI mobility, like our GI system has a lot of nerves, and whether like anything intra-abdominal he's at risk for. So the fever would make me worried that like, hey, are we dealing like an infection complication of what is going on? But an infection wouldn't explain like the dysphagia, the dysarthria, the head drop, the proximal limb weakness. And I think your point of like, hey, did we miss another substance that he ingested? I think is a very fair point. Uh, with organophosphates, you can have this like intermediate syndrome that is a complication of like organophosphate poisoning that often like, oof, I think it develops like within a few days of it. And it's like notorious for causing like proximal muscle of weakness and head drop. Uh, And I believe it can have some cranial nerve abnormalities. The one thing I remember about it is that like it can cause like respiratory muscle weakness, but thankfully this patient is already like intubated, so we have that protected. Um, and so I would like keep this patient, if I'm worried about that, I'll keep this patient intubated. I'm not sure if there is any, and I'm so curious to learn if this is in fact the intermediate syndrome, if there's any treatment for it. I did not know that, but I think it's mostly like supportive therapy. But it's basically this kind of like a delayed a weakness that you get from the organophosphate syndrome. But I think like actually botulism is a great thought as well that can cause a lot of bulbar symptoms. Yeah, and I think like the fact that he's a farmer, like, it kind of like helped that he has like perhaps access to pesticides, and potentially it's another um, supporting factor, like, oh, maybe like we're in the right track with like the organophosphates. But yeah, that is where I am at. Masa, any additional thoughts?
No, but I like that you said about how he could have aspirated something, because maybe like the neuro symptoms happened first, which then caused the fever later. But yeah, I like that thought.
Yeah, yeah, I don't know. I can't remember honestly if the syndrome causes fevers. I don't, so I would worry that maybe there are two things happening here. But I'm really stretching. I'm at the extent of my knowledge about the organophosphates. All right, Iman, back to you.
Yeah, I feel like I'm working with you guys in ICU right now. Excellent approach. Yeah, so actually the atropine and plydoxime is like 24 to 48 hour, but if patient is having the excretion continuously, you can give continuously. Yeah, and then I will go on with the past medical history. So past medical history, no known chronic illness, no diabetes, no hypertension, no prior psychic or hospitalization. As I mentioned, his job is farmer, and he has a chronic alcohol use for 20 years. And I'm going to go to vital sign. Temperature was 38 Celsius. Heart rate was 120. BP was 130 over 90. Respiratory rate was 23. It has been a little bit calmed down. And generally diaphoretic, excessive oral secretions, HENT, pinpoint pupil, a moist conjunctiva, neck rigidity, C, tachycardic, normal, S1, S2, no murmurs, pulmonary, bilateral decreased chest extension with a diffuse lower jaw crepitations, abdominal soft, non-tender, active bowel sound, neuro, very important, DTR 1 plus, proximal muscle power 3 out of 5, and distal 5 out of 5, no sensory loss or focal deficit, but urinary incontinence was present. Okay, I will end it here.
Okay, so he doesn't have any past medical history, so like nothing pointing towards like a stroke, like it doesn't put him at a high risk of a stroke or anything like that. We already mentioned he's a farmer, so he's at risk of like exposure to different pesticides and substances. He's a chronic alcoholic, or he uses alcohol he's been using alcohol for 20 years. So what kind of alcohol complication? It could still mean that like he's more vulnerable, or yeah, like immunocompromised. And then moving to the vitals, there is some sympathetic stimulation. His heart rate is elevated, his blood pressure is elevated, and he's diaphoretic. And he has the pinpoint pupils. He has excessive oral secretions. I wonder if like the atropine is now like exacerbating his symptoms. Maybe he's like given a bigger dose than he would need. And then he does have some lower zone crepitations. Diffuse lowered. Okay, so that's like bilaterally. Because I was thinking if it was in one spot, then that would be an aspiration. But if it's bilateral, I don't know. Maybe like I'm not really sure actually what to do with the fever. Is this like a new pneumonia? Yeah, I'm not really sure. What do you think?
Yeah, it's tough. I got like this is tough because there's like so many different things involved. And yeah. Oh, I got so excited about organophosphates that I forgot the other substance involved are sometimes nemesis alcohol here. Um, and I worry that, in the setting of like, focusing on the organophosphates, that we forgot about the alcohol withdrawal. And personally, I did. I got so excited. And thank you so much for bringing it up, Amasa, and thinking about like, oh, are we dealing now with like some of aspect of like alcohol withdrawal? And, I don't know how many days we are into the hospitalization right now, but oftentimes with alcohol, initially you get like kind of like those tremors, anxieties, the mild tachycardia, and within like a 24 hours, if people have, or depending on how much they drink, for how long, their physiology, hallucinations, and then within 24 to 48 hours, you often think about like seizures, and 48 and a few days later, delirium tremens. And, with the fever, now the tachycardia, despite having organophosphates on board, I think thinking about DTs is not a bad idea. And oftentimes, like if this patient is sedating, choosing medications that help treat underlying alcohol withdrawal would be helpful. And depending on what medication that is chosen, I'm not sure what this patient is on for sedation, and just like making sure that this, even if he is intubated and sedated, he is. Oftentimes, like people are placed in propofol, and propofol tends to treat alcohol withdrawal as well. So I would be curious to learn if he is on propofol. If he hasn't been, then I think like at least like putting in some benzos on board wouldn't be a bad idea. In From that perspective, I think if we get some more imaging, I'm not exactly sure, to be honest with you, Masa, what I do about the diffuse and the findings in the lower zone. So I would like start with the chest X-ray, whether that is like potential complications of the barotrauma, whether that is, aspiration. It could be bilateral at times, depending on the degree of it. I'm not sure. So I would just like start with some imaging and some lab work. And I think the neuro findings, what are your thoughts on the neuro findings? Or any other comments about um, the exam?
I still don't know what to do about the neuro findings. I do have a question because I'm a little bit confused. So organophosphates cause sympathetic overstimulation, and then atropine was the opposite, right?
It causes parasympathetic overstimulation, and atropine, per my knowledge, is a lot of you just do it for secretions. So it's a lot of the times is done for the secretion management of people with organophosphates.
Okay, got it. Okay, I'm not really sure what to do about the neuro exam, but yeah, I'm looking forward to imaging for the lungs. And yeah.
Yeah, and oh, thank you, Sana, yes, for bradycardia as well. Yeah, for the exam, I think it just kind of highlights that proximal muscle weakness. That kind of goes with like kind of the organophosphate intermediate syndrome. Um, and so that is like what I would be the most worried is that we're just like still seeing the organophosphate toxicity here. I think in general, like organophosphates um, can be absorbed through the skin, and I'm not sure, like making sure the patient's been cleaned with like towels and stuff. I know he ingested some, but I think that's another thing to make sure there's not more of those substances around at this point. All right,
Yeah.
Martha, go ahead.
1 second. What's it called? So he was treated already with atropine and pralidoxine, and he's still having these symptoms. So could this be like his the organophosphates just like haven't fully left his body, or like could it be like something else that's causing this?
Yeah, I think exactly. Like, is it multiple substances at that point? Are we still dealing with that, like organophosphates? Sometimes, like organophosphates can have just kind of delayed effect, just like a lot of like infections. You can mess up your. I don't know the mechanism of the intermediate syndrome, but like how you can have an infection and you can have a delayed reaction, whether it's like autoimmune or something to it. So I don't know the mechanism of the intermediate syndrome, but it can kind of have like delayed effect. I believe it also can cause like delayed neuropathy down the road as well. It's just like messing with your nerves endings. That is a very inelegant way of explaining it, but here we go. All right, Hiba, back to you.
Yes, amazing discussion. Yes, so Sana mentioned about the bradycardia. So we were concerning, organophosphate usually cause bradycardia, but this patient is now having heart rate 120, and we thought it's maybe the reaction from the atropine, and also a patient is having temperature 38, so that might be the possibility. I will give you the lab. WBC was 13.8 K, increased neutrophil 80%, hemoglobin 8.7, platelet 180 K, MCV 84, acetylcholinesterase was 110, which is decreased, BUN 24, creatine 1.6, it's been increased from the baseline, sodium 129, potassium 3.6, AST 90, ALT 75, bilirubin 1.4, mildly elevated, glucose 180. And chest x-ray was done by lateral lower jaw opacities, but no pneumothorax.
Okay, so his white count is elevated with neutrophilic predominance. So there's definitely an infection going on. And with the chest x-ray, we can see bilateral lower zone opacities. I think there might be two things going on here, like an infection and the poisoning, the substance poisoning, especially with his chronic alcohol use, that definitely puts him at risk of aspiration, along with the substance that he ingested, which caused the dysphagia. I think he might have aspirated either his saliva or like the alcohol or anything. The acetylcholine esterase. I'm not really good with this, so if that's elevated, then yeah, I'm. Does that mean I don't know? I'm not really. Oh, so that's low. Okay, so that's low. Okay, I'm not really sure, how like what to think of that. His liver functions are a little bit deranged. I guess that's just because of his prolonged use of alcohol. And his creatinine is a bit elevated. That could be like pre-renal from, like, I guess just his acute illness. And yeah, his hemoglobin is low, but his MCV is normal. So I'm not really sure why it would be low. Is he like bleeding anywhere, or like he's losing hemoglobin somewhere, but his MCV is normal? I would expect it to be elevated in someone who has chronic alcohol use. But yeah, Charmaine, what do you think?
Um, Yeah, a lots of things to chew on, and you're doing an awesome job also like walking through and picking out the abnormalities. And yeah, I totally agree. I think with that chest X-ray finding, like the tachycard, sorry, the fever, the leukocytosis, I would like worry enough about an infection that I would consider empirically treating with antibiotics. I think your point and Himon's point is very well taken about like atropine causing like elevated temperature, tachycardia, and I think that is absolutely a point well made, and possibly contributing for sure. I think in terms of like, sorry, you mentioned the acetylcholine levels. I think low corresponds to organophosphate toxicity, if I remember correctly. So I think it's another kind of marker that like, oh yeah, we might be in the right path because low levels means like you're not producing as much, so there's like low, yeah, there's like more enzyme inhibition of the enzymes. So oftentimes I think how low it is correlates with the severity of the toxicity, and I don't know what a 110 level means, so Human has to help us with that. I don't know how low that is, but I think that's how you use it, as more of a kind of a supportive of evidence that like, oh yeah, this kind of like corroborates what we're worried about in this case. um, yeah, I think there are, in terms of like the other abnormalities, like, I'm not surprised like this patient has an AKI, this patient has a lot going on. So it's more like, okay, what is the etiology of AKI? Are there like volume down with everything that has been going on? So kind of like thinking about your three buckets. But again, like I think that is like problem number 4 or 5 down the road, not the thing that I'm currently focusing on. However, the other thing is like with atropine, as I think uh, it can cause like bowel obstruction at times. I believe if you use it too much, that can cause like urinary retention. So make sure has a full. I think this patient might have a fully in. Making sure he's not retaining, and then work up the AKI a bit more, and the sodium as well. With everything going on, I'm not surprised this patient also has hyponatremia. I think at this point, I love just getting my urine and serum studies to better understand it. But then again, it's like not his number one problem. We have a bigger fish to fry at the moment. But not forgetting about in IC about your problem number 8 and 9 here. Any other thoughts, Masa?
Not really, but like now, okay, so now that he has an infection and we treat him empirically with antibiotics, what else would you do? Because he still has like that weakness in his neuro exam. Would you just get neuro on board, or like what would be your next step here?
Oh, for sure. I think like absolutely, like getting neurology board would be very helpful. I think in terms of like a bilateral, like proximal muscle weakness in this context is pretty pathognomonic for kind of the organophosphate intermediate syndrome. But other causes of like proximal muscle weakness, like autoimmune disease, it would be odd for him to have like developed this in this context. But making sure we're not missing any other etiologies, whether they would want like a brain imaging. He's at high risk of seizures as well, so something to be aware of. So I think like getting neuro involved, as well as just kind of like supportive therapy to get him through it. And I wonder if like measuring the acetylcholine activity level, acetylcholine enzyme like would also be helpful in like kind of determining trajectory. I'm not sure about that, but yeah, I think like when it comes to the treatment, I'm a bit like out of my depth. So like getting neurology or ICU colleagues and like speaking with the poison center about like kind of the next things to do. And from ours, well, while I'm like getting help from our experts about those aspects of the care, making sure the things we do well, right? Like this patient, like make sure he's having bowel regimen, he's having bowel movements, because he is going to be at risk of someone who developed ileus. Making sure whether that's like at the bilateral is like infection, I would treat it. It might be atelectasis, but in this context, I would just doesn't want him to get another hit at this point. Again, like as we talked about, the hypernatremia care work this other aspect of his care up. All right, Himan, back to you.
Yes, thank you so much. Yeah, we are considering all those electrolyte is due to some dehydration of patient is having, and also since he was a chronic alcohol use, so it's possible he's malnutrition. Maybe he had a iron deficiency or other folic acid or vitamin B12 deficiency. So we are going to work up on the anemia workup and. Yeah, so as Masa mentioned, you are amazingly smart. Yeah, so we did actually the acetylcholinesterase. It's organophosphate irreversibly inhibit acetylcholinesterase. So the person was having 110, which means less than 10%. It's really fatal without ventilation. It's the really like low. So yeah, and go back to that Masa mentioned about amazing about the lung why it's causing this fever and lung, and we did a sputum, and the sputum grew Acinetobacter and Pseudomonas. We considered that this was a ventilation associated pneumonia, and the blood and urine, there was no growth. So we start with the antibiotic, meropenem and IV colistin. And since this patient has been 5 days of mechanical ventilation, we thought that the patient met extubation readiness, and criteria will be like a stable hemodynamic, awake, following commands, and improved respiratory strength. And we did a cough leak test was performed before extubation, and it was okay. And yes, so go ahead, and I'll give you the the last allocate like later.
Masa, what do you think?
I don't know if I have anything to add here. So we had ventilation acquired pneumonia. So yeah, that's what caused the fever. Okay, I thought he got the fever. Oh, he got the fever after he got mechanically ventilated. Okay. Yeah, I don't know. I mean, here we just like have to cover for gram-negative antibiotics, which has already been done. Yeah, I wonder how he's feeling now after extubation, if he's still having any dysphagia or dysarthria. I mean, I guess if he's ready for extubation, that means he's able to protect his airway pretty well. So maybe he doesn't have that proximal weakness anymore, which means I guess that just means that the poison that he ingested finally got excreted. But yeah, that's all I really have. What do you think, Sharmin?
You are so great. Absolutely. I really love, Himan, your point about like, and thank you for clarifying that the 110 is like less than 10%. And that is like kind of the severity of it. And then that's when I really, really worried about like respiratory muscle weakness. And I think like kind of the fasciculation, all the CNS stuff is also kind of like, it tells you like, oh, this is a high this is a patient at really high risk of respiratory muscle weakness. And I think like what I love is like all the prep that you all went before extubation, like making sure the cuff leak, making sure like he can manage. Because the other reason is like, can he still manage the secretions when you extubate him? If he still has a lot of secretion and can't manage those, he's at high risk of like getting another aspiration. And also like making sure like he's in the support mode so he can actually breathe on his own. He doesn't get like he doesn't tire out. So doing all of that before extubating him to give him the highest chance of success. And I'm curious, what was his neuro exam doing before extubation? Did he still have the proximal muscle weakness, Hemon?
Actually, his proximal weakness was getting better and better every day. So yeah, but then the story is not over yet. We did intubate. I mean, like the test was before X. We did extubate it, but developed post extubation stridor shortly after. What can we do? Must you can you give us any treatment or any suggestion? What can we do?
Okay, I read one time that intubation can cause pressure on the trachea, which can cause ischemia or infection, or like weakness, and so that could cause the stridor after you extubated, or it just could like tracheomalacia Kruti mentioned, or it could mean that maybe he just wasn't ready for extubation and he still has that proximal or like bulbar symptoms, but I guess here we have to do a tracheostomy. What do you think, Sharmin?
Yeah, scary. This patient is really, really keeping us on our toes, right? I think with I haven't thought about this in a while. So for prosthetic extubation stridor, it makes me worry that like whatever is happening is that the airway is narrowed for whatever reason. The most common cause of is oftentimes you see it when people have been intubated prolonged for a prolonged period of time, whether and often the first thing I think about is like laryngeal edema that you have like stridors. And then sometimes you can get spasms that can cause a stridor as well. Um, if he's having like a hoarse voice, then you can think about like vocal cords not working as well, and and it has like expiratory visas, as you mentioned, like tracheomalacia is another thought. So I think oftentimes we do like you want to, depending on the patient's saturations, ability to do the airway, protect their airway. You want to like do a laryngoscopy to view what is happening. Oftentimes they might have to um, get reintubated. If it's like mild, I believe we can like give steroids right away, thinking that most likely causes edema. And I don't know if there was another nebulized thing that I forgot that we often give. Is it epi? I can't remember. Oh, it is epi. Heman is whispering epi. Thank you. And then for like severe cases, they may need to be reintubated. So that was just me a lot thinking out loud with you guys. So what would I do in the moment? I think in a moment I would give steroids. I would give nebulized epi, monitor them really closely. I don't know if ICU folks can do laryngoscopy or call ENT staff to the bedside for them to help us with. And then like monitor to see if the patient needs to be reintubated. If you're having a really hard time intubating, then tracheas might need to happen. But hopefully like it's most often spasms or edema, and most of the times it gets better. But woof, I am sweating, Himon. What happened?
Amazing, amazing. Like you got everything. Yeah, so we were really worried. We are just beginning the ICU and we thought, oh, maybe intubate again. you know. But the patient was managed with oxygen, IV corticosteroid, and nebulized racemic epinephrine. And then he did an NIV suffer, not the intubation, but NIV suffer for one day. And then yeah, showed a good clinical recovery. So we heard the stridor, but it was not really like causing pathological stridor. I think it was due to the muscle weakness that he had for long days. So yeah, so as Charmaine gave us a solution, we follow it, and yeah, he got really better. So yeah, so the diagnosis was organophosphate poisoning with the intermediate syndrome and ventilate associated pneumonia.
Wow, what a case. We had to dig deep. Himan, thank you so much for presenting it in such a great fashion. You're just a master presenter, my friend. And thank you so much for sharing. It's like, it's one of the reasons why I love VMR so much. It exposes me continuously to the things I don't get to think about on a daily basis. And I get to learn from all of you, at times with like sweating profusely trying to remember. And Masa, incredible job, friend. Any reflections?
Thank you so much, He, for this wonderful case. You presented it very well. I haven't thought of organophosphate poisoning in a while, so this was a really good refresher. And yeah, this was lots of fun. Thank you, Charmin, for teaching me all these things.
Oh, we learn together, friend. It's a group effort. That's what I love the most about medicine. And I think the most important thing to remember about this case is that we're not done yet. This is someone who came in with ingesting organophosphates and alcohol, and as he's like improving, getting help from our mental health providers and making sure that he is well supported, because what we don't want this to happen again, and helping better understand what led to this event and help support him as he gets better. He's I think that's also, now that Hima did an incredible job getting him through this, is to kind of like the next step is to getting our psychiatrists oftentimes involved, and supporting this patient. Um, all right, Himan, anything else that you want to share about this? Any teaching points or anything else? Thank you so much for helping us and guiding us through this case.
Yeah, if you guys don't mind, because since I'm in ICU, I always learn something. So cough leak test. So when the endotracheal cuff is inflated, air flows only through the tube, right? But it's when deflated, air should leak around the tube. So we measure the difference between the leak, like a cuff leak volume inflated and deflated. And if it's more than 110, it's safe to extubate it. If it's less than, we have to worry about possibly edema. So we give steroid and delay extubation. That's it.
Oh, that is so important, Himan, and thank you for thank you so much for highlighting that. It is absolutely like one of the things you should do before extubating a patient. Um, oh, all right, team, thank you so much. All right, Julia, thank you for scribing, and Magnus, I can't wait to hear your teaching points.
Yeah, thank you so much, Himon, for such a fascinating but also really complicated case. I haven't thought of organophosphate poisoning since med school, so that was really nice to that you presented this, and Masa, you did a really fantastic job, I think. So we started with a 37-year-old man who was found unconscious and after ingestion of alcohol and an unknown substance. So here, first we should prioritize an ABC approach and treatment before diagnosis to stabilize the patient and secure the airways. And then in terms of the diagnosis, we can think of the mnemonic for altered mental status. So we think of metabolic, infectious, structural, or toxic causes. And it's very important here to not forget obtaining an CT head to look for any bleeding or trauma, and also to get a blood sugar to rule that out really fast. Here, we knew that the patient had been drinking alcohol, so alcohol intoxication or alcohol withdrawal can both lead to altered mental status. But we also saw from all the other accompanying symptoms that he had symptoms of organophosphate poisoning. And organophosphate inhibits the acetylcholinesterase, which prevents the breakdown of acetylcholine and then leads to overstimulation of the cholinergic receptors. And these are mainly divided into two categories, which are responsible for the symptoms. So we have the muscarinic receptors that are present on glands, heart, and smooth muscles. So overstimulation of these lead to bradycardia, salivation, diarrhea, urination, and then bronchorrhea, which I hadn't heard of before, but that is overproduction of watery sputum. And then we also get overstimulation of the nicotinic receptors, and those are present on the skeletal muscles. So we also get fasciculations and cramping, and you could also develop seizures. And we treat this with the atropine that blocks the muscarinic receptors, or the pralidoxime that binds to the organophosphate and then reactivates the acetylcholinesterase enzyme. And in this patient, he also developed, one day after, he developed a fever, dysphagia, and weakness. So we thought of, could this be an uncomplicated infection? And this patient would be very prone to developing an aspiration pneumonia due to vomiting and altered mental status, but also a ventilator-associated pneumonia, which this patient had. And with the proximal muscle weakness, we also found that this patient had intermediate syndrome, which is a delayed effect of organophosphate poisoning, leading to proximal muscle weakness, and also respiratory muscle weakness and neuropathy. So this patient was intubated, and a few days later he was extubated but developed this stridor. And the differential for that is that we have some kind of airway narrowing, which could be due to edema, spasms, or the vocal cords not working properly. So he was treated with the steroids and non-invasive ventilation, and ultimately he improved and had a recovery. But the final diagnosis was organophosphate poisoning with intermediate syndrome and also ventilator-associated pneumonia. So thank you so much for such an amazing journey. Yeah, I have to read much more about this. That's for sure.
Magnus, that was amazing. I'm just always blown away with how fast you all put this teaching points. So my brain doesn't work as fast. So mad respect for that. Thank you so much for brilliantly summarizing it. Big shout out to Masah, Hima, and Julia, Magnus, and all of you for all the comments in the chat. Sorry, I couldn't keep up with all of them, but thank you so much for all your inputs. Can't wait until next time. See you then. Bye all.